Is anybody there yet?
Okay, Dr. Morse, let me make you the co-host.
Do I need to click on the start video thing here?
So, Dr. Morris, can you share your screen?
Sure. I'll click on the little green button here and.
Yeah, we can also hear you pretty loud and clear.
Good. Now, okay, there's my presentation here. Yeah, after the last hour there, I figured I better get out a little bit earlier here. You know, I should have said something in the first 5 minutes. There's no sound, but I always assume it's just me that screwed up, you know.
No, it's fine. This computer gives us a lot of trouble sometimes. I finally figured it out though. Awesome. I can see your PowerPoint.
Good.
Perfect. Dr. Morse, I think everyone will probably be back in like another 5 minutes. So then we can probably, I'll let you know when we'll begin.
Sounds great. Okay.
Thank you, Dr. Morris. Thank you. Dr. Morris, can you hear me?
I sure can.
Alrighty. Just one more minute and then we'll begin. I think just people are
I
Back here. Mhm.
did I put my little video thing so people can see me too?
I think it adds to the effect. Yeah.
All right, good. It seems I can't have a camera kind of looking at all you guys so I can see what I'm talking to, you know. Now let me see, how can I still, is there a way I can shrink it so it doesn't block half my slides on my screen here? What do you guys see in the chair when I have this up here now? Do you see just
Yeah.
me or do you see a bunch of other
No,
stuff?
no. We see the entire slide and just a tiny corner. We have your video there. So
Because what I'm seeing on mine right now is me plus you plus Janine plus the list of whole people. Can I shrink that down somehow?
And you should have
Hide, oh, hide thumbnail. There it is. Okay, well,
Yeah.
no, that doesn't do it. Yeah, it does. Oh, good. Can you still see me now that I hit the thumbnail?
Yep, we can see you, and the slide is nice and clear as well. So I'll mute myself now, Dr. Morris, and then you can go ahead. Thank you.
You're welcome. All right. Okay. Well, make sure I can figure out how to do this right here. Okay. Well, hi there, everybody. I'm Zach Morris. It's nice to talk to you guys again. I'm going to be coming from my home in my den here. What's the weather like out, by the way? It's really storming here. It's really black and cloudy out. Anyway, we're going to talk today about spirometry guidelines, performance, and interpretation. And I know actually your schedule said we're going to talk about methacholine also, but that's just way too big of a topic. We can spend a whole hour on that, just the new guidelines and changes in those. So we're going to confine things to spirometry today, and we're going to, really pushing the time limit on that one too. There's a lot to do. Next week we'll talk about volumes and diffusion. I do not have any disclosures. Okay, the last set of guidelines for spirometry, they were published at the end of 2019. And one of the first things they had in the front there, a really nice table. I got 2 slides in this, so we'll go through it pretty quickly, is basically the diagnosis, the use for spirometry. It's very helpful in diagnosing patients, to evaluate symptoms, signs, abnormal laboratory tests. It can be used to, oh, by the way, can you guys see my mouse also? Can I use it as a pointer?
Yeah, that works.
Good. Okay. Wasn't sure if that's just something only I could see. Okay. We can also use spirometry to measure physiologic effects of disease or disorders, for screening individuals who are at risk of having pulmonary disease, to assess preoperative risk, and to assess prognosis. It's helpful in monitoring in patients for therapeutic response to therapeutic interventions, monitor disease progression, follow patients with exacerbations and their recovery from the exacerbations. We can monitor for adverse effects of exposure to agents that injure the lungs, and we can actually look for adverse reactions to drugs. It's good for disability impairment. We use it in rehab programs, part of insurance evaluations, and also to assess for legal reasons. And there's other good uses for it too. We use in research trials for epidemiologic surveys, to derive reference equations. It's becoming more often in use as pre-employment and lung health monitoring for at-risk occupations, and also to assess health status before beginning at-risk physical activities. Now, there's really no absolute contraindications to spirometry, but you really need to use some common sense, because the guidelines, they do give a fairly large table of things you need to think about, and really these can be broken into 4 categories. They're kind of no-brainers, really. Anybody with any kind of unstable cardiovascular disease, whether they just had an MI the past week, they have problems with hypotension, they have unstable arrhythmias. Those are kind of no-brainers. An acute pulmonary embolus. Patients that have had recent eye or brain surgery or aneurysm within the past 4 weeks. Kind of interesting, because the ophthalmologists, I know when they talk to their patients and patients mention that they're going to have spirometry, the ophthalmologist will often tell them a couple of months. So I just really don't push it in those situations at all. Patients that have recent sinus surgery or ear surgery within the past week, or an infection, you don't want them blowing hard and blowing out their eardrum. Again, another no-brainer here. Patients with recent chest or abdominal surgery. They hurt, they're not going to be able to perform very well. Obviously, a patient with a pneumothorax is not a good candidate either. The infection control issue is kind of interesting, because before COVID, remember, look at the date, these were published before, the COVID thing started. Our big concern back then was, might a patient had TB? A patient may have had hemoptysis or something like that. because when that would occur, we'd have to break down all the equipment and put new tubing on and scrub down the room. We weren't really that concerned about virus type things because, we use really good filters. They're changed between patients and they screen out most of the viruses. The particle size is adequate and whatnot. But COVID put things in a whole different dimension. So I'm sure there's going to be new guidelines being issued here by the ATS. They put out some preliminary things at this point. But who'd have thought we'd run into a situation where just by walking down the hallway or somebody breathing, you might catch something potentially fatal. Okay, now, before you do spirometry, there's some things that need to be things that should be avoided. Smoking, vaping, or water pipe within an hour before using it. That's trying to avoid bronchospasm, acute bronchoconstriction from the irritation. Consuming intoxicants within 8 hours should be avoided too. I mean, patients need to be coordinated and comprehend what you're doing and have adequate ability to perform the tests. The patient shouldn't perform heavy exercise within an hour because, again, that can trigger acute bronchospasm. And they should avoid wearing clothing that substantially restricts their full chest or abdominal expansion. Now, one of the things that would always come up over the 20 years when I was there was, bronchodilators should not be withheld prior to testing. The only time they really should be, if the doctor wants to test without a bronchodilator, it should be something that he tells the patient ahead of time himself. You really shouldn't have a protocol for that to automatically do it. For 20 years now, it's really been frustrating. Actually, before I retired, somebody back in the 90s had a protocol with appointment scheduling to tell all patients, new patients, if they're on inhalers, to hold them. And it was carried over to tell every new patient and everybody. And every time I thought I got rid of that, at least 2 or 3 times a year, somebody would pull something out of a drawer, appointment scheduling. There's so many scores of people there, and it would pop its ugly head up again. But that's something that should not be withheld. But the one thing we are lax on quite often is the text should record when the last doses were taken. And that can be very helpful to the doctor when you see the patient, be familiar with that, especially if they took their short-acting agent ahead of time. Now, they do give recommendations, how long you should hold therapy if you want to hold it. To see if the effects worn off. Short-acting beta agonists, you should give it up to 6 hours. Short-acting muscarinics, like Atrovent, up to 12 hours. LABAs, like formoterol and salmeterol, you should hold for at least 24 hours. The ultra-long LABAs, up to 36 hours, and the longer-acting muscarinics, like Spravato or tiotropium, it's really, you need to be safe, you need to hold it up to 48 hours. Now, what's considered an acceptable effort? Well, you need to have at least 3 good efforts. They tell you once you reach 8, you've kind of reached the point of diminishing returns. They don't say stop doing any after 8, but they do let you know you probably kind of might be flogging a dead horse at that point. Subject can stop if they're too uncomfortable, if they're getting lightheaded or they're getting pre-syncopal. You need to make sure the volume time curves achieves 0 flow. In other words, the patient's expiring less than 25 milliliters for greater than or equal to 1 second at the end of that effort. They need a duration expiratory time of 6 seconds. Less than 3 seconds is considered adequate in a child under 10. You need to keep in mind, though, that patients that have obstruction, they can continue to expel air for more than 15 seconds before they get to 0 flow. And I'm going to show you some examples of that here in a little bit. Unacceptable tests. If a patient's coughing, you don't want their teeth or tongue in front of the mouthpiece. There should be no hesitation or extra breaths during the effort. You do not want to have a patient doing the Valsalva maneuver, causing glottic closure, which causes cessation of airflow. And air leaks at the mouth can be a problem too, especially in patients with neuromuscular disease like ALS. They have great difficulty sometimes later on in the disease of getting a good seal around the mouth. And dentures can also cause problems. That patient should do the test with their dentures, not without. You also need to make sure you back extrapolate times 0. Okay, now what I mean by that is that's one thing that's kind of overlooked, but it can become very important because if you have a slow, okay, this curve right here is the beginning of a volume time curve. This is the FEV1, and this will keep going off to the side here. But we're cutting that off to make our point here. Okay, we're just showing the initial flow here. If you have a slow start to your spirometry, okay, it's going to underestimate the FEV1. Okay, this could be out here because you're starting later before you really start blowing. But zero time here, you may not be pushing any air out for a quarter second. Okay, so how you back extrapolate to make sure the test is adequate. Now, the computers often do this, by the way, automatically. Sometimes the techs have to nudge it a little bit to get it to mark it appropriately. But you use the steepest part of the exhalation curve. Okay, you draw a tangent through that. Okay, down to the x-axis. Okay, and that becomes your new time zero. Now, what you have to do is find out how much volume the patient has eliminated at that time zero by going back up to the line itself, going over to the y-axis, the volume, and see how much air they've actually expelled at that point. Okay, now the back extrapolation, time zero to be an adequate test to accept that test needs to be less than 5% of the FVC or less than 150 milliliters, whichever is greater. I'll just tell you just a little quick math. That amounts the FEV1 of 3 liters. Anything over 3 liters, then you have the 150 rule comes in automatically. Less than that, you have to do the 5% rule. Most adult patients, and FEV1, the vast majority, especially up to the middle age or so, is greater than 3 liters. Now, the guidelines also tell us spirometry should be graded. Okay, now for the last few years before I retired there, it took a lot of effort, but we finally were able to get the techs to grade hopefully they're still doing this, but to grade every diffusion effort, grade A through F to let it know quality. Now, why that's important is because what we did is I did an analysis of all the tests we've done over like the previous decade or so and found out like with diffusion, our compliance rate was only about 70% that were adequate. And about a third of our tests were not considered adequate by ATS standards. Once the technicians, we spent a few afternoons kind of learning the grading process. And once they learned that and had to grade themselves, I reassessed the data after that over the next year. And our grade, over 90% of our tests then achieved grade A status, which was tremendous because that's what the guidelines recommend, greater than 90%. I was getting ready to start doing that with spirometry, and that's what kind of all things the crap hit the fan at that point, and I retired and everything else. So we never got around to it, but something should be done. So let's talk about what a grade A spirometry effort is. Okay, you need at least 3 acceptable efforts down here. And they need the 2 best efforts. Now, the best efforts, you pick the ones with the 2 largest FEV1 plus FVC. Okay, those values, the FEV1 and FVC, must be within 150 milliliters of the other effort, acceptable effort. What makes a B effort is if you only have 2 acceptable efforts within 150. Now, one of the things that happens downtown, unfortunately, because pre-COVID things got really busy at times. The clinics are in crunch. The port technicians are doing twice the number of tests was really considered acceptable for a lot. We're doing massive numbers. So a lot of times when they had 2 acceptable tests, they're almost right on the volume time curves. They would stop there, and that's okay. But we have to realize if you do that, we call that a grade B. Okay, still may be a great test. We do call it a grade B. Grade C test, now you're allowed to have 200 milliliters difference between the 2 efforts. Grade D, it's up to 250. And when you get greater than 250 or 1 acceptable effort, if you only do 1 effort, it may look great, whatever, but that automatically becomes a grade E. Okay, it's not, you may think it's a grade A test, but if there's only 1 effort, it's considered a grade E. Now the U grading, kind of interesting because there's kind of a very fine line between U and F. F is nothing's acceptable. A grade U rating is you have 0 acceptable tests, but 1 might be usable. I thought about that a little bit. The only way I can really see that might have a usable one, quite honestly, if the tech thinks it's a crappy test, is let's say the FEV1 is like 80% of predicted. The test is kind of all over the map. Well, that could be very useful information because that even though the patient can't do the test, he's probably got a pretty adequate lung function. He's got an FEV1 that high. Okay, now spirometry, let's talk about interpretation. That's where we want to spend most of our time today. And that spirometry was actually invented in 1846 by a guy named Hutchinson, Royal College of Surgeons. He actually reported predicted values also, went out and grabbed a bunch of people off the streets of London. And but it's kind of amazing that it wasn't until 1991 that the ATS finally, or anybody, but the ATS was the first one to do it, to develop guidelines for interpretation of pulmonary function tests. Now, the guidelines we've got to be kind of careful with because they're very helpful and they're very good. They give us a lot of very good information, but there's a lot of stuff they don't tell us or they just completely omit. And that's because we just don't have good information. And hopefully a lot of the take-home message you're going to have today is in the latter half of this lecture here. I'm going to show you a lot of those examples with things that aren't in the guidelines that we need to consider a reading test because the guidelines just never addressed it. Hopefully they will in the future with further research. Seems like pulmonary function testing is one of the more boring areas to do research in pulmonary medicine, and not as many people do it as other areas. Okay, now, since 1991, those guidelines and all subsequent guidelines have clearly stated when we interpret pulmonary function tests, we use 95% confidence limits of predicted to determine if someone's normal. Not percent predicted, we use 95% confidence limits. They also stated that Z-scores could be helpful visualizing the degree of abnormalities. I'll have another slide on that in a little bit. They state that regression equations should be adjusted for age, height, sex, and race. Now, up until the last set of guidelines, the last couple of years, demographics was also included in that. Demographics talks about race and sex and things like that. One of the things you need to be careful of, though, make sure that, let me give you an example here. It's not unusual to see, a couple, 3 tests every year when I was reading these, where a patient, their tests were all in black or all in red before, showing abnormality, and then they come back in this visit and their numbers are almost identical, but now everything's it's the opposite. It might have been black, they're all marked in red as being abnormal. Then you say, what the heck is going on here? Well, make sure that the sex is correct, make sure the race is correct, because it will change predicted values. And when a patient is first registered, they put their medical record number in, the text put in all the demographic information. And then the next time the patient comes back and every subsequent time, they punch in the medical record number and that brings up the same demographics. So if somebody's not really paying attention and they made a mistake once before, it's going to keep propagating the mistake until somebody picks it up, maybe 2 or 3 years later, 4 or 5 tests later. And doesn't happen often, but it does happen. So keep that in mind. Okay, what's a Z-score? Well, I don't profess to be a statistician, but to me, really a Z-score, the way I see it, is just another way of saying standard deviation, because a Z-score have an average of 0. One standard deviation, a Z-score equals Z of 1 equals 1 standard deviation. I'm not really sure what that adds to anything. They make pretty graphs. I know the allergy department, when they print out their tests, they always have little Z-scores and all these little graphs and bars, and it looks really pretty and stuff. But, really, I'm not sure if that just might be confusing things more, because on a Bell distribution, a 95% confidence interval is 1.64 times the standard deviation. And we mark that anything on the test that's in red, it's beyond what we consider the confidence limit on that one. So they do mention using that. They're not real strong advocates of the guidelines, but they do throw it in there. And that's why I felt compelled I should mention something here. So when we see a test here, how we put our reports out there is anything that's abnormal that falls outside the limits that we consider normal, we mark in red. We put parentheses and we mark it in red. Okay. We determine if something's normal or abnormal by if it's outside the confidence limit, but then we'll use a percent predicted to determine the relative degree of abnormality. In other words, how bad is that abnormality? Now, all the guidelines since 1991 state do not use percent predicted to determine if a value is abnormal. Once, then, as I just said, can't say it enough, if the confidence interval is abnormal, then use the percent predicted to quantify how abnormal it is. They also state quite firmly since 1991 in multiple sets of guidelines do not use rigid cutoffs that define normal. And what they're, in particular, they're addressing things like the GOLD statement. Notice I didn't use the word guideline because GOLD is not a guideline, it's a statement. And they say the GOLD that an FEV1 to FVC ratio less than 70% defines COPD. Well, you got to keep in mind that GOLD is for classifying and managing COPD, but unfortunately it's kind of been, morphed over the years into interpreting every pulmonary disease in the world. It's meant as a tool for classifying and treating COPD. It's a very good tool. You need to know it for your boards. But I can almost guarantee you, because every year for the last several years now, there has been questions, 2 or 3 questions regarding, the difference between GOLD and the guidelines and interpreting. Are you going to get more positives, more negatives, this sort of thing? So let me kind of show you that so you know what you're looking at when you see that question on the boards. It'll become very easy. We'll start off by saying GOLD defines an FEV1 to FVC ratio less than 70% as diagnostic for COPD. In other words, from the ages of 20 all the way up to 100. This is the FEV1 to FVC ratio as a percent. They say if you're less than 70%, you have COPD. Okay. Well, the reality of the situation, as we published this in Chest a while back, is that for like NHANES, this is the reality is the predicted value looks like this. Okay, for the FEV1 to FVC ratio. The lower limit of normal parallels it as a straight line also. So once you reach the age of 40, or a little just slightly above the age of 40, your lower limit of normal is now less than 70%. Okay, and it keeps dropping. So in other words, for young people, and young people do not have COPD in their 20s and 30s, these are asthmatics. What happens here in this younger group that are above 70%, they're calling them, Gold is calling them normal when they're not. These are abnormal patients that are being called normal. And once you pass the age of 40, it gets even uglier. These are normal patients still. They're still in a normal range. We're now calling them abnormal. Okay. Now, what's the incidence of problems doing this? The misdiagnosis rate with gold? Well, in that younger group under 40, 50% of patients with obstruction, those are mainly asthmatics, are reported as normal. 50% of them, because most asthmatics are not COPDers. You don't have FEV1s of like 20% or 15% are predicted like we typically see toting their oxygen tanks in the clinic. These are patients that, they feel pretty awful and they're just a little bit below the normal range. Well, you're going to miss 50% of those asthmatics by using gold in that criteria. There's a lot of people that still do. In the older group, you're going to start by missing at least 20% of the older adults that diagnosed with COPD that are really normal. Okay. And that keeps getting, as you get older and older, it keeps getting worse and worse, your misdiagnosis rate. Again, to reiterate it, can't say it enough, gold, oops, I didn't mean to do that. Gold is meant to classify and manage COPD. Now, I can show you a whole bunch of articles on this, but I just want to show you one example here. You got to be careful when you read the literature. This was an article that was published in JAMA on June 25, 2019. What often happens when something kind of comes up like gold and then it starts to stick and it keeps sticking more and people start using it for other things and extrapolating kind of gets out of control after a while. And I got to tell you, there's been a lot of major societies that have written letters to ATS, ACCP to talk about gold. People on the gold committee need to be a little more explicit instead of making that a tool for interpreting every pulmonary disease in the world. A guy named Bott published in JAMA. I can't believe that this actually didn't receive a lot more criticism than it did, but Bott's concluded that a fixed FEV1 to FVC ratio less than 0.7 better predicts admissions and mortality for COPD using the lower limit of normal. And the reason that really caught our attention here is right about that time, the hospital, they asked me and Dr. Roulette, they had a committee, everybody's concerned about billing and CPT codes and readmission rates and things. So they formed a committee and they invited Dan and myself or Dr. Roulette and myself to be on this, on the committee for COPD to try to improve outcomes, this sort of thing. Okay, so one of the first things we had to do then is we had to go through all the patients, find all the patients over a certain period of time, several years, that had the diagnosis of COPD that were hospitalized. And we had to find all those that don't have pulmonary function tests, spirometry, diffusion. Mainly we wanted to find out, are they even classified correctly? And we found that approximately, and this is all that this Bott guy did, he just used a hospital database of codes. Okay, we found that over a third of our patients at Ford Hospital admitted with a diagnosis of COPD did not have COPD. And we've confirmed this by these are patients that actually had pulmonary function testing that were normal. Okay, so the diagnosis of COPD, it's become like a wastebasket term. It's used too indiscriminately in patients who are admitted with dyspnea. And I used to see this all the time. Okay, these patients often had other causes for the dyspnea, pneumonia, heart disease, asthma, ILD, and a large percent of these we dealt even further, dove even deeper in the medical record. They had like either no or minimal smoking history. So I think that's why, I think rather than what Bott's study should have said, it better predicts that admission and mortality patients hospitalized than using a lower limit of normal. And it's not just for COPD, because over a third of those patients for other diseases. Okay, well, the same problem holds if we try to do this for the forced vital capacity, use a fixed ratio. When I was a fellow and for a number of years after that, the standard mantra was a forced vital capacity less than 80% of predicted, no matter what your age, 20 to 100, was considered restricted. So what I did, just to kind of give you an example here, we're going to look at a male 5 feet 9 inches tall. Okay. And from the age of 20 to 100, this red line up here assumes that he's 100% of predicted. Okay, he's right on where he should be. And it's 69-inch male here. And what I wanted to do is I wanted to show you how the lower limit of normal, the 95% confidence limit, is a moving target, okay? That if we plot that lower limit of normal as a percent predicted, let's see how much it falls, okay? Again, these are the abnormal patients that are considered restrictive, a reduced FVC, but if you use that 80% line, you're calling them normal. Once you get past your early 60s, that lower limit of normal falls below 80%, and it keeps falling. Notice the cutoffs, they keep getting wider and wider and wider as you get older. Now, it even gets uglier in females, and especially Black females. That's what I'm showing you down here. This is a young Black female, 65 inches tall. And she, at the age of 20, she never is at 80% of predicted. Her normal limit starts around 77, 78, or 78 to 79% of predicted. And it falls even more rapidly. Look how this is the lower limit of normal. By the time she gets to be 80 years of age, she could be around 65% of predicted and still be normal. Okay. Well, this becomes important because the guidelines tell us that if a patient, they've been telling us this since 2005, if a patient has a normal vital capacity maneuver, lung volume shouldn't even be performed because the patient's not restricted unless you're looking for something else. And there's a lot of setters out there that, let me just check something. I see a chat here. Okay, well, we'll come back to the questions here in a little bit. See a really good one there. It's a transgender. That's a really important thing to address, and I'll throw that into my talk here. Okay, now see if I can shrink this out again. Thank you for that question, by the way. That's very important. Okay, but we'll get to it. If I don't, remind me at the end. Okay, as I was saying, if the lung volumes, a patient has a normal vital capacity, lung volume shouldn't be performed. There's a lot of centers out there, when committees that I've worked in different groups when I was on chest committees here, that because the labs are kind of busy like ours, what they use as a criterion, if a doctor orders complete PFT, if that patient has a normal vital capacity, no matter which vital capacity is normal, they do not continue to do lung volumes. They stop at that point and they save lab time and expense. Now, okay, let me see if I can get this to move now. There we go. Okay, well, spirometry can be displayed in two different ways. You know, we're all familiar with a flow volume loop, and I put a normal here. I intentionally made these two guys half the size of this one, and the reason I actually should have made that half as big as that one, just to kind of remind you that, you know, the printouts are scaled. You know, notice on this patient, normal patient, big guy, that goes up to 8 liters volume, it goes up to 16 flow. When this COPD, or to make a better fit on that, they'll make this the same size as this one, but it's only gonna be 4 liters here. You see all the scalloping. And look at this patient with restrictive lung disease. They're gonna show you a graph as big as this one. Actually, I should have cut it in half again, because notice if you look at the actual volume down here, this patient's got an FVC of only about 1 liter on here. So flow volume loops can give you information looking for airways obstruction and stuff, but I don't think they're anywhere near as useful as looking at the volume time curves. Okay, exact same 3 patients here, looking at their volume time curves. See a patient has 2 tracings here. Actually, it's at 3. I can't tell. They're right on top. It's a great test. You can't even tell if there's more than 2 there. I think there is 3. They're right on, yep, right there. They're right on top of each other. Normal test. Okay, I always love to ask the fellows, so what's this line over here? And every now and then there's kind of a pause, a pregnant pause there, kind of, you know, quizzically looking a second. Well, remember, we run out of paper. Okay, once the patient blows 8 seconds, then it starts up and it just keeps coming back again on the left. And we noticed that in this patient with COPD. We see what causes the, you know, the slow uptake or expiration of air in the FEV1 that causes that scalloping effect. The patient gets to 8 seconds, he keeps blowing, 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 another 8 to 10 seconds here, and then it keeps going a little bit further. We're talking about almost 20 seconds here. Okay, well, the nice thing about the volume time curves is you can actually quantitate. You can quantitate trapping. For example, you say you need to have a 6-second expiratory flow at that point, and that if you stop at that point, my goodness gracious, this volume between here and here is over 1 liter between that 6-second point when he finishes blowing. And so you got to let them make sure they achieve that 0 flow. In other words, no more air is coming out. And then the ILD patient, you see that rapid upstroke and real flat due to that restrictive effect. It's like well under 1 liter here. Okay. The nice thing about volume time curves also compared to flow volume loops, we can see a patient has a bronchodilator that shows up in red here, COP patient, there's scalloping in here. And you see there is a little bit of improvement, but it's really hard to quantitate on a flow volume loop how much improvement there is, as opposed to on a volume time curve. You know, we actually have liters. You can actually print these out a full page. You can print them out with tick marks in here. There's a lot of options on there. So you can actually do your calculations off the volume time curve to find out what the FVC is and bronchodilator improvement. As you can see here that this patient from when he started here, or when he finished his pre-effort, 2.5 liters. And after his bronchodilator, he's gained another ½ liter almost, or about 400 cc's. So volume time curves, to me, I like to have those on the reports. I think they're more useful actually than the flow volume loops. So the flow volume loops can tell you if there is, significant obstruction. Now, you're also going to see a board question pop up here and there. And that talks about, the one they love to throw into you is when someone has airways obstruction, like an intra-airway lesion. And the one they love to throw out is the variable extrathoracic lesion. Well, a lot of times the fellow sits there and thinks and tries to memorize, is this intrathoracic, which one has flat at the bottom, which one's on the bottom. Well, you can actually think it through. And that's why I put these little diagrams here for you, because if you have a variable intrathoracic lesion, the expiratory is flat, inspiratory looks kind of normal. Well, that's because, there is, even though the airways are relatively fixed, there is a little bit of flexibility to them. So if you blow out really hard, you're compressing the chest, and if that's a little bit variable in there, you're squeezing it down and you're flattening the inspiratory loop. As opposed to if you take a really deep inspiration, you're putting traction forces on the airways, and it kind of opens it up a little bit, and you get the normal inspiratory. The trickier one is the variable extrathoracic, because that's the opposite. And the question is, well, why does it do this? Well, the expiratory one, you fill up your lungs with air, you blow it really hard. Because things are more flexible up here, you're literally blowing it open. You're not compressing it with the chest here. There's no chest surrounding it here, just neck soft tissue structures. And you're pressing it and you blow it open, you get the normal inspiratory or expiratory loop. But then the question is, why on the inspiration does it go flat when you're sucking in? Well, that's what we call Bernoulli's principle, where areas of increased airflow velocity reduce airway pressure. Think about the airplane. This is why a curveball curves in baseball. This is why an airplane flies. If you imagine an airplane wing, it's flatter on the bottom and it's more curved on the top. So as you're moving forward rapidly, the air that travels over the top has to travel faster than the air on the bottom. And by traveling faster, it creates more of a negative pressure effect. Okay, it lowers the pressure and it causes lift. It lifts the patient or the airplane up. And that's the same reason you see that flattening on the inspiratory loop, Bernoulli's principle. Okay, now, there's dozens of predicted values out there for spirometry. Up until 1991 and 2005, the guidelines recommended equations that were adjusted for age, race, sex, height, and local demographics. Notice I have a blue here, demographics. That becomes important because 2019 reporting guidelines that came out, at that point, they weren't the spirometry guidelines or the reporting guidelines. They recommended that we should now use either GLI or NHANES for our predicted authors. Our lab uses NHANES. They stopped mentioning local demographics. Before then, all the previous guidelines said you should pick equations based on all this, but also based on your local demographics. In other words, NHANES were collected here in the United States and West Virginia. Some of these other authors now that in GLI, they're Eastern European. They come from all over the world, really. Okay, well, what is GLI then? Well, GLI is called the Global Lung Initiative. It was a group of docs got together in 2012, and they went out and collected from consenting authors data sets that are worldwide. They wanted to try to create one universal equation that fits for everybody: blacks, whites, etc., different ages. They included ages 3 to 95. Age extremes were limited in numbers, down to the younger ones and the older ones. They then originally were given 160,000 patient data sets, and they basically eliminated over half of them. They ended up choosing 70,000. And a little over half of those were children and adolescents. Now, they only really studied the values for FEV on the FVC and the FEV on the FVC. They reported predicted values for the midflows. But what's kind of interesting, they did that because they had the numbers. But the guidelines since 1991 have been telling us that this value is kind of useless. It should not be used, and it shouldn't be on our reports anymore. It's how dysfunctional that value is, and I'll show you why in a bit. Okay, reporting guidelines from September 2017, as I already mentioned you could use GLI or NHANES, especially NHANES if you have been using them previously in years like we have for continuity, for comparison. And it's important to mention that GLI, the large percentage of patients in the GLI were the NHANES patients. They were up around the, $7,000, $8,000 population just in the Caucasians alone. Well, the GLI equation, it's really kind of a complex mishmash here. This is the exact same equation as down here. This is when you put it in logarithmic form. This is in the exponential form here. And what they do is, they have age is height. Age is A, H is height. And then they have all these different coefficients that are A, B, C, D1, D2, depending on your race. It's like a different number for ethnic group you put in here. And then the group number is either 0 or 1, depending on race. But the thing that always really caught me was the spline. What is a spline? Oh man, I spent so much time trying to figure out what the heck a spline is. These are actually the equations for males and females from very young ages to 3 up. And notice here in the late teenage years, there's a blip. It kind of goes down and back up again. Okay, well, they had to try to explain this. What they did was they formed an equation that was a line. And then for the variation of that line, that's what the spline is, depending on your age. Now, there's no equation for a spline. You actually have to go to the appendix in the article, and there's an Excel table that you have to look up the patient's age and to see what the spline factor is to add it in. Now, I don't think there's anything really, my opinion, I don't think there's anything changing, like somebody gets worse, gets better as you get younger and older cross thing here. Most of the pediatric ranges, they stop up around 18 to 20, and then the adults start after that. And there's very few studies that combine pediatrics with adults. So I think what you're doing, you're seeing when you're trying to merge different curves together, and you get this in-between thing from different authors in here. I tried to, I went to the authors, talked to them on numerous occasions, Quainjar and others, and said, gee whiz, this spline thing, that really kind of upsets me. I mean, not a statistician, but it's not really a real equation then. And the explanation was, well, nobody on the committee really understood, how, well, their comment was the statistician they had. She was actually a young graduate student from China. They said how brilliant she was. And they really couldn't understand it either. But they kind of took her word because she was just so brilliant. The spline thing, they thought it was just beautiful the way this was done. And so I spent like the next year trying to find her to get more information. I could never find her. She kind of moved around to several other institutions now. And last I heard, she was in Canada, but unfortunately, I could never get her to answer one of the emails. Most of them got rejected coming back, so she kept moving around. Okay, well, GLI reports 5 race equations. They have one for Caucasians and Blacks. They have for Northern Asians. They have South Asians. And then they say for Middle Easterners and Hispanics, they use Caucasians. For all others, somebody says other, they average them all together. Okay, well, here's where it gets kind of interesting. They didn't use Hispanics. They had a lot of Hispanic authors, including N. Haynes. They had a lot of patients in that group, like 1,000 or so, but they didn't use them because a lot of the other Hispanics, they needed to have more than one good data set to include them. And most of the data sets of Hispanics actually came out of Mexico, different areas, Yucatan, Mexico City, and actually different population groups, again, different demographics, Indian versus more Spanish ancestry, et cetera. And they were just all over the map. So they said, we just don't have reliable ones. So they said, we're just going to use Hispanics for Caucasians, or Caucasians for Hispanics. Now, the Northern Asians and South Asians, that's where it gets kind of interesting because, well, how do you know if somebody's North Asian or South Asian? Well, when they went back in the data, they found, it's kind of easy to know if somebody's from Mongolia or, Korea, or maybe they're from Thailand or Laos or something like that, Vietnam. It's kind of easy at that point. But what if you're actually Chinese? And that's where it gets kind of interesting because the biggest complaint I've heard from people I've worked with, like at Mayo and Salt Lake City and these committees, and is the patients are supposed to identify what their race is. Well, one of the problems is patients that from this country, a lot of times they don't know. Well, they may know where their grandfather was born. They're Chinese, but they don't, they use the Weihe River as the boundary. It's a river that runs all the way across China. Okay, well, they don't, is that north or south of the Weihe River? Because I don't know where half the cities are in China, and there are more than half, probably all the cities in China, except maybe 2. And the Weihe River, when you ask them that, they said they didn't have a clue where it was. And it gets even funnier because we've actually had some Chinese residents and fellows in the past, and since these came out, and I asked them, well, are your ancestry north or south of the Weihe River? And they didn't know either because it turns out that Weihe River in China is called something different. And after I showed him the map, or one of our fellows, and he looks, oh yeah, that's called the such and such. Can't remember the name now. So that's where it gets a little dicey in that north and south part. Now we use N. Haynes here. We report 3 races: white, blacks, Hispanics. And we still stay with it. 2005 guidelines that say you could use Black equations for Asians. They fit pretty accurately on that. It is a little different than this up here, but it seems to work pretty well for us, and we avoid a lot of that confusion. NHANES goes from ages 7 to 81. Okay. Whereas remember, GLI goes up into the 90s. Well, let's find out by, how much difference there really is between using the NHANES and the GLI. Okay, we'll just kind of talk about the adults right now, but notice the GLI. This is in, they're the gray line in here. This is the coefficient of variation for the FEV1. And NHANES is the dark black line. Notice how for a good part of that thing, they're almost right on top of each other. The coefficient of variation, even down here at the age of 20, is about maybe between 1 and 2%, and up here it's about even less than 1%. So even if we extrapolate NHANES, even to the older age groups up into the 90s, it still fits pretty closely. So why haven't we switched to GLI? Well, we're sticking, like with all the previous guidelines, using a population similar to ours. You guys down the road may change to GLI, and that's okay, because that's where half the world's going now anyway. But as I said, our population was actually taken just a couple states away out of West Virginia, and they made up the majority of the data. GLI only uses the FEV1 and the FEC. NHANES data includes data for the FEV3, the FEV6. Their confidence intervals are very similar. We do not test children under the age of 7, and that's as far as NHANES goes at that point. An allergy clinic who does do that, though, they use GLI. And as I already mentioned, if greater than 80 years of age, GLI really doesn't vary that much. NHANES, if you extrapolate their equations to older ones. GLI grouped Hispanics with Caucasians. We have a fairly large Hispanic population in Detroit here with Mexican Town, and we have our database, it's huge in the thousands. And as I said, GLI did not use authors without multiple sources, and because their Hispanic sets were unreasonably variable from various countries. So we do know that Hispanics are different than Caucasian. The equations are different. So we, again, have used NHANES from that standpoint. Now, as I already alluded to, when you see a spirogram, if the spirogram is entirely in black, it's normal. Okay, I bring up this example, an 81-year-old, because the FEV1 FEC ratio is 65. A lot of people say, well, geez, this patient by definition has COPD by goal. Well, no, the confidence limit for a white male is about 9.5 to 9.6. So, and the blacks, it's a little bit larger, down to 10.5. So this patient can be down to 60% FEV and FEC and still be considered normal, well below that 70% mark. That's why I bring this one up. Now, when you interpret a spirogram, you always look for obstruction first. The order of precedence, the gold standard is the FEV1 to FEC ratio. We look at the pre-value. If that's normal, we look at the post-value, number 2. If these are obstructed, we need to look no further. We skip all the rest of them because we got obstruction. We move on at that point. Okay. We also use the FEV1 to FEC ratio that's in the guidelines. That's the third order precedence. Actually, newer guidelines are going to say, and new equipment is going to use the best, we'll have the ability to use the best FEV1 with the best vital capacity, whether it's inspiratory, expiratory. Unfortunately, we don't have that capability right now, but we will in the future. Then we go down, the next order precedence is the FEV1 to FEV6, pre and post, and I'll show you why we do that in a few slides. And then after lastly, we look for the midflows, the FEV3 to FEC pre and post. Okay, once we determine there's obstruction, we stop, we are in algorithm, we say there's obstruction, and then we go to the FEV1 as a percent predicted to determine how impaired they are. These are arbitrary cutoffs, anything below 70% FEV1 is moderate, below 60. These are arbitrary cutoffs. There's no literature that's going to say this is whatever. It's just a way of quantitating it. Once you get down below an FEV1 of 35%, we call it predicted, we call it severe impairment. Now, just a quick example, patient with mild obstruction here. His ratio is reduced. We need to look no further because it's 79% of predicted. It's in black. It's normal. So we call this mild obstruction. It's above 70% of predicted, which makes it mild. Moderate obstruction, again, we have obstruction, FEV and FEC ratio. FEV1 now is below 70%, but above 60. So we now call it moderate obstruction. Severe, when it gets down below 50%, obstructed, 36% ratio. 46%, it's below 50%, but it's not as bad as 35, which we'd call severe obstruction. And we see the scalloping here. Okay, every now and then you're going to see one of these guys. Okay, notice here, the only thing in black here is the FEV1 to FEV6 ratio with a normal FEV1. We're going to call this mild obstruction. Question is why? Okay, well, the rationale. The National Lung Health and Examination or Education Program back in 2000 advocated using this value as a surrogate for FEV1 to FVC. The reason they did is because it requires less effort. It's a more consistent endpoint. In other words, like a patient with COPD, when they get to 6 seconds, I've already shown you, they can have another liter coming out after that. Okay, it's less variable than the FVC. A lot of patients, if they do that 6 second effort, that should be consistent, that 6 second point in each individual. It's kind of interesting. We found the confidence limits are smaller for the FEV1 to FEV6, being a more consistent endpoint, as opposed to 9.5 for whites and 10.5 for blacks. They're like about 10 to 15% lower. This becomes kind of important too, because part of this national education program was there's always been a push to have family doctors use spirometry more in a diagnosis. And they get these little handheld spirometers, and they have all these little whistles and bells and things that tell you what the quality test is that nobody uses them, understands, at techs or nurses. But one of the things they have is they'll have like a little beeper. So when a patient blow, they get to 6 seconds, it goes beep, and then the nurse pulls it out of their mouth and says, you're done. Well, you know, that's where this number becomes really helpful. And it's built into a lot of the different handheld spirometers now with their own set of regression equations. Okay, well, we wanted to find out, well, how significant is it? We looked at over 23,000 adult spirograms, and we found that in patients with COPD, it's the only abnormality we found in 4 to 5% of them. Okay, it doesn't seem like a lot, but you know, when you do thousands of patients, it can kind of add up. And we found the reason this occurred is because there's shorter expiratory times. They average around 8 seconds in COPDers, and most of our other COPDers are like 14 to 15 seconds. Okay, so 8 seconds does not allow complete emptying of the lungs. It's because of the air trapping. Now, on repeat testing, we found that if these same patients, if their expiratory time was 1 second longer, they dropped the FEV1 to FVC, now fitting the gold standard for obstruction. But we did find it was not quite as sensitive as the FEV1 to FVC. We miss up to 14% of patients when it would still be normal in there. So it really shouldn't replace the FEV1 or FEV1 to FVC ratio, but it does give additional information. Give you a graph here, the patients we studied. In red here, this is the expiratory times on the x-axis. This is the number of patients. And we found here, total tallying up the patients, those that had only an FEV1 to FEV6 ratio reduced, we can see the mean expiratory time is around 8 seconds. And the ones where only the FEV1 to FVC was reduced, this was their distribution of expiratory times. And we found that this group over here, that if they had a second test, they blew 1 second longer, they shifted into this group. We also found, when we compared that FEV1 to FEV6 group to those that had only an FEV1 to FVC reduced, which is the gold standard of obstruction, they had a greater degree of hyperinflation compared to them with the higher TLCs and RVs. P-values are all less than 0.001. They had more air trapping with a high RV TLC ratio and decreased FVC and FEV1. They had more diffusing impairment, and they had significantly lower airway conductance measurements. So they were actually a little sicker group than if only the FEV1 to FVC was reduced. Now, sometimes you're going to see this number being abnormal. The only abnormality is the FEV3 to FVC. Everything else is in black. Well, first question is, well, why are we using that for mid-flows? And, you know, why is the FEF2575 so horrible? Well, let me just give it a graphic example here. This is the normal distribution. This is if you're plotting the FEF to 2575, the mid-flows, as a percent predicted. You know, remember back when I was a fellow, we said anything less than 80% was considered abnormal or obstruction. Oh, whoa, wait a minute here. Look at this. This dotted line's the 80% mark. This is the normal. This is smokers. The other one's never smokers. Look at the never smokers here. That 80% is like just a little bit below the mean. If you're looking for a 95% confidence interval, the lower limit of normal is going to be somewhere we're down here around 50% of predicted. So we plot out the FEV3 to FVC distribution, and look how tight it is. There's only a little bit of difference between smokers and non-smokers. So it's a very, very narrow curve, which is kind of, you like to see that kind of thing. Now, here's what's even more interesting. The confidence intervals are half as wide as the FEV1 and the FVC. Remember, I told you the confidence intervals for the FEV1 and the FVC are 9.5, 9.5, 9.6 in whites and about 10.5 in blacks. Well, look here. For the mid flows here, the FEV3, they're like 5.8 and 5.6. They're half the difference. Crapo was one of the first guys in the early 1970s that validated this, identified a smoking population when this became abnormal early on. It's been revalidated by a number of people, including yours truly here. What we did, we wanted to do something a little bit different in our study, though, at chest. I wanted to find out, a lot of people said, well, geez, does this number really mean anything? I mean, is it a sign of disease? Really? Get serious here. Just another number out there. Well, we did then. We said, well, we have a database of 100 and some thousand people. Back then, we had about 60,000 we did this. So we said, we wanted to ask the question, is an isolated reduced midflow versus normal spirometry associated with other pulmonary function, physiologic or pathological findings? Okay, so we compared it to people with normal spirometry when this was the only abnormality. And yes, sure enough, all their p-values are less than 0.001. Okay, actually they went out to about 6 zeros, but when you report the literature, they don't want more than the 3 decimal point one. Okay, associated with past smoking, as others have proven. There was a male Caucasian predominance, which is a little surprising to us. We also found that this group compared to normals, even though all these values here might have been still in the low normal range or normal range, but compared to normals, they had more signs of, they had higher TLCs, sign of hyperinflation developing. They had higher RVs, again, sign of hyperinflation. They had higher RV TLC ratios, a sign of air trapping. They had lower specific inductance, going along with the airways obstruction. And interestingly, they all had lower diffusions, which is a measurement of loss of lung surface area. So in smokers, this may be one of the earliest signs of emphysema developing. Over the years now, if we looked at this, if we didn't use this number, then the question is, if we say this number does mean obstruction, okay, and we included the obstruction category, if we didn't use this number, how many would be missing? Okay, we found in our database obstructed patients, it was the only abnormality in 16% of our obstructed patients. That's like 1 out of 5. That was kind of staggering. This became very useful information, at least in my clinic, and people and smokers that otherwise have a normal spirogram using GLI and say, oh, I got off easy. Well, if this number is abnormal, which will be 1 in 6, about 1 in 6 of them, they didn't get off as easy as I thought. This gave me a lot of hard evidence that I could use that convinced them, hey, yeah, there is some damage being done here. Okay, now we also use the FEV1 to SVC ratio. We do that because the guidelines say we do that. We should do that. Okay, and here's a patient, the only abnormality of ratios, third order precedence is that ratio. It's reduced, okay, because the FEV1 is low, it's considered mildly obstructed. Okay, this number comes from the lung volume measurements, the vital capacity. The computer is smart enough to know that when he calculates the total lung capacity, we'll tell you how to do that next week. When we calculate total lung capacity, you need a vital capacity to add that onto the RV. If the vital capacity maneuvered during TLC is less than the other vital capacities, the computer's going to pick the best one there, and it's going to use that instead to calculate the TLC. Okay, this is a situation here where its VC is higher than this. The quality control measure we'll talk about, if this number actually is the same as the FVC, then this probably wasn't a very good test because the machine's picking the best one to use. Well, what are the issues with this ratio? Well, the ATS and European Respiratory Society since 2005 said recommended using the best vital capacity with the FEV1. There's no predicted values for this ratio. Okay, so they said, well, use the FEV1 and the FVC ratio, predicted values. Well, we already pointed out it's not even measured during spirometry, it's part of TLC maneuvers and not spirometry. And where it really gets controversial is a couple pages later in the guidelines, and the guidelines are all written by different people, and they paste them all together at the end. Okay, the guidelines just a couple pages later clearly stated and gave the references that SVC maneuvers are often greater than the FVC. Okay, well, and then I gave you the reference there, the actual guideline where they actually stated that. And I think that becomes important. So I've always looked at that number with being a little bit nervous, using a different predicted value for that than somebody actually studying an SVC, a ratio with the SVC. Okay, what do we call a bronchodilator response here? Well, we use 12% and 200 cc's. Okay, the value FEV1, for example, has to meet both criteria. Improved by 12% or 200 cc's, not one or the other, it's both. The reason for that, it takes into account big people and little people. Okay, a little tiny little old lady that's 5 feet tall, she might change by 15 or 20%, but only be 100 milliliters. The converse, you have like a 6'6" guy. He might change by 400 milliliters, but it's only a 10% change. So that's why you need both of those values for the FEV1 and the FVC. Now, the guidelines do give a lot of other authors out there of what's considered significant, but this, what we use, the most popular one, and that's a whole nother issue and another couple dozen articles we could discuss with other things that are out there. But there is considerable variability between studies over years, what they consider significant. Now, one of the studies I liked, and it didn't make it into the guidelines this last time, and I was kind of surprised because this guy, Ward, hypothesized that clinically important bronchodilator response would be associated with survival. So he looked at nationwide databases, tens of thousands of people, and he said, well, if you express the FEV1 as a bronchodilator response as a % of their predicted, that avoids differences of size of biases. And they found that if you had a change in the FEV1 of greater than or equal to 8% of predicted, that showed the optimal survival advantage, not the 12%, whatever on there. And it makes sense. You don't need an absolute value because this is being adjusted against a predicted, which takes into account the differences in sizes. But like I said, didn't make it in the guideline, but I threw that out there just to show that there's a lot of different opinions out there. We use the same criteria compared to previous tests on different days, same numbers. Where does that come from? Well, again, loose associations in the literature. That 12% 200 cc's came from population studies, not intra-individual variability. You got to be careful about that because intra-individual variability over time shows changes are actually less. You'll see that pop up in your practice sometime. You see a patient that hasn't had PFTs, had a spirogram like 8 years before because predicteds decline with age. You think, well, geez, they should decline appropriately just as the aging process. But you'll see more often than not, those numbers are almost identical in that patient. So intra-individual variability is different than population studies. It's one of the reasons when I found out early on in my field, when I submit publications, when I would try to use a patient's change over years with diseases, comparing it to like a changes as the % predicted of the population. Nobody would accept that because of the intra-individual variability rather than what happens in population studies. But anyway, we use the same number. That's the take-home message there. And then we're going to end up with the last question here, our last slide here, where we have obstruction, but now, unlike all the other ones, I showed this patient has a reduced FVC. Now the question is, is this due to air trapping or due to restriction? And we're going to stop there because basically that's next week's lecture to talk about. Now, let me go back up to let me kind of chat thing here, because that very good question that was asked here in a transgender person. Let me give you an example. My clinic had a previous Army Ranger, like 6'3", that basically became a woman. Came in, looking very attractive, big hat, dress. And the technician came to me and said, Dr. Morse, what do I do here? Because, this guy, he's never had hormone treatment, no sex changes, nothing, always still physiologically totally a male. And, I realized how sensitive the issue was because he insisted I'm a woman now. And this patient was being seen, obviously he's there for a reason. He's having problems with dyspnea. We're not really sure what the cause is. The fellow had already seen the patient at this point. And so what I did, I went into, this is a very important learning situation. So what I did was I went into the room and I went into the lab with the patient and explained to them. I was very kind about it, the best way I could explain it. But I said, it's really important trying to find out, if you're, sometimes abnormalities can be very mild. But basically what's going to happen is if I list you as a woman, women's predicting, you're still, even though I know you're a woman now, but physiologically and hormonally right now, you're still a man. And a man at your woman at your same size, a female is going to have much lower predicted values. And anyway, we could get really false results here. So to get the greater degree of sensitivity, at least for right now, I said we need to kind of run you against predicted values and document that. So we know if there really is something abnormal. And the patient accepted that at that point. I don't think they were entirely happy with it on that, but they understood. So I think that's where information education becomes very important on that. Okay, any other questions? I'm trying to figure out how to use the chat thing here. I think I have to, Oh, there it is. That was the only one so far. Okay. Oh, can we use genotype instead of gender on sheets? I think that's probably something important for the comments section. In that, if somebody wants to state they're a different sex, and of course, I don't have a problem if they are on hormonal therapy or if they've had, sex change things and in that conversion process. I think you can make more of an argument, but if they're still physiologically a male or female, I think for the predicted values to be accurate, we just have to maybe explain in the comments why we did what we did on that for the sake of accuracy. They use, predicteds that are based on physiology. All right. You guys still there?
Yes, Dr. Morris, we were just muted. Thank you so
Okay.
much, Dr. Morris.
Okay, no more questions? If so, I guess we move on to chest X-ray conferencing.
Yep. Thank
Okay,
you.
if anybody has any personal questions, by the way, give my email address on the talk there. I'd be happy to answer them also.
Got it. Thank you, Dr. Morris.
You're welcome. Okay, bye.